I'm going to be talking about gender differences in substance use disorder. And I always tell people when I do this talk, the pictures are stock pictures off the internet, except for the first two, and I'll explain those in just a minute. And I've tried to change enough details so that the patients won't be obvious. So first one is a 90-year-old man with a long history of heavy drinking, eventually evolved into alcohol use disorder. He lost his father to suicide when he was in his teens and likely began drinking after that. He had multiple car accidents, multiple episodes of pancreatitis. He lost his wife at age 50 due to alcoholic liver disease. He married her sister and continued to drink heavily. When he was in his 60s, his wife finally looked at him and said, "You got to stop drinking." He went into inpatient treatment, and after that was a lifelong member of Alcoholics Anonymous, lived a fairly healthy life with no relapses to alcohol, eventually dying at age 90. Next patient is, I put husband, actually his wife, to the first patient. Long history of heavy drinking. Her mother nearly died giving birth to her younger sister because of complications from rheumatic heart disease, and she died when the patient was 18. As a child, she was quite well known for being mean. She was also quite capable. She played piano for Mary Martin, who was the very first Peter Pan. She was a very heavy drinker throughout her adult life. She remained employed despite this and was the best poker player around by many accounts. She claimed she could hear what the cards told her. Her home life was marked by multiple episodes of domestic violence from her husband. She developed alcoholic liver disease when she was 53, went into a hepatic coma. The doctor said she was going to die, and she shocked everyone by actually waking up from it. She managed to get her nurse to bring her alcohol into the hospital, and she died 6 months later, and she was drinking steadily the whole time. And people may have guessed, but these were actually my grandparents, and this is the reason I became interested in addiction medicine to begin with. So I am going to be talking about gender and substance use disorder, and I just wanted to give a couple words about terminology. None of the studies I found looking at gender and substance use disorder actually specified cis or transgender. I'm going to assume the vast majority of them are probably cisgender, but I really don't know. And I have generally tried to use the terms either female or male or woman and man that the study did. And I want to start with a historical perspective on gender and substance use disorder, because I think people often think that, women's problems with substance use disorder actually began, 40 years ago with women's lib and all of that kind of stuff. And this is really not true at all. The history of illicit drug use in the United States actually goes back at least 150 years. Opiates were widely prescribed in the 19th century. They were the sort of treatment of choice for both cholera and dysentery because we didn't have much else at that time. And they were widely used for a lot of psychiatric conditions in particular, but many other conditions as well. There just wasn't anything else available to treat anything. And recreational use in the United States really started after the Opium Wars in the mid-19th century. At that time, large numbers of Chinese immigrants came to the United States, and there were really horrible working conditions for most of them. They were often very far from their families, and it was a very lonely, difficult time. And the estimates at that time were that roughly 20 to 25% of them ended up smoking opium. And so between oh shoot, I don't have the date. I think it was like 1862. The sevenfold increase in the opiate use in the general population from less than 1 in 1,000 in 1842 to 5 per thousand. I think it was somewhere around 1862 or 1872. And cocaine was also widely available during that time. And at the end of the 19th century, about 2/3 to 3/4 of opium addicts, not a term I would usually use, but that was what the source referred to them, were women. And at that time, women were generally viewed to be kind of hysterical and, lots of womanly problems. And the only treatment available was opium. So they were given a lot of opium. And as a result, a lot of them developed opioid use disorder. And so the majority of people with opioid use disorder in the 19th century were actually women. And women were considered just less capable of managing painful disorders, female problems, neurasthenia, things like that. At that time, we couldn't vote. We had to regularly get pregnant, and domestic violence was widely accepted. So I guess to me, it's not surprising that there was a lot of women with opioid use disorder. Starting in 1914, drug use was criminalized by the Harrison Act, and the clinics sprung up around the country for people who suddenly needed treatment. At that time, about 1/4 of the clients were women. And the clinics were shut down at that time with the fairly repressive anti-drug approach being promoted by the federal government. And so there was very limited treatment options available for both men and women through the 40s and 50s. Most of the treatment that was available through the prisons. And you got a lot of therapeutic communities, religious-based programs, outpatient non-maintenance programs. They were really geared towards male patients. So there wasn't really any treatment available for women with substance use disorder back during that time. Methadone became available in the 1960s. At that time, again, women were about 25% of the clients. By 2005, it had risen to 35%. Moving to stigma. Stigma affects both men and women with substance use disorder, or just even who use substances, not even worrying about substance use disorder. Women who use substances are generally much more stigmatized because of two myths. The first is that women who use substances are unrestrained sexually, and the second is that they are bad mothers. And women in general are less likely to develop problems because of substance use, partly because they're less likely to use substances. But when they do develop problems, they deviate more from the female norm just because women are not supposed to use substances at all, and they're certainly not supposed to develop a substance use disorder. And so they develop they deviate a lot more than the norm than a man who has an addiction, because men are kind of supposed to do that anyway, more so than women in a lot of people's eyes. So substance use disorder tends to present differently in men and women. Start with just a few cases. Patient is a 52-year-old man with multiple medical problems. He has a history of hepatitis C that was treated. He stopped using alcohol so he could get treated for hepatitis C. He also has a history of alcohol use disorder that has been in remission since he was treated for his hepatitis C. Has some alcoholic liver disease, which is stable. He has not had any alcohol to drink in 20 years, really feels like he made the best decision for his health, but he frequently, every visit he comes in, talks about that he no longer has friends because the only way he could ever socialize was while he was drinking. All of his friends drank. And once he quit drinking, he was never able to get another group of friends, nor able to feel comfortable going out with friends. Next patient is a 38-year-old woman who has opioid use disorder. She's been stable on buprenorphine since her pregnancy 2 years ago as far as opioids. Her partner also has opioid use disorder, and he also has severe alcohol use disorder and moderate stimulant use disorder. He went to jail starting midway through her pregnancy, was in there for about 9 months, and she was completely drug-free during that time, no problems at all. Once he was released, they got back together. They both started using cocaine. He also started drinking heavily at that time. He's had 3 arrests for domestic violence since his release. She's kicked him out multiple times, but they always end up getting back together, and her cocaine use is accelerating. So men, as I mentioned, are more likely than women to use almost all types of illicit drugs. Women probably use prescription drugs at greater rates than men, but even that, some of the studies that I've looked at have not shown that. But we think that women use prescription drugs at higher rates than men. Men are almost twice as likely to have drug dependence. And again, I'm taking these terms from the sources. It's not what we would refer to it now. Men have higher rates of alcohol use, including binge drinking, than women, except for teens. The rates are similar in the teens. Men have higher overdose rates than women, but women are increasing much more rapidly. Women heroin users use smaller amounts, less likely to inject. They are more at risk for overdose deaths than men when they start using. They are more likely to survive long term. I have not found any specific data on fentanyl. The most recent survey that they did on drug use did not actually include fentanyl separately, which I found really frustrating. So I'm waiting for this study to come out, hopefully within the next year or two, that will include fentanyl. Women between the ages of 45 to 54 are more likely than women of other age groups to die from a prescription pain reliever. So think about that because we often think of people in that age group as much less at risk, but they are actually more likely to die than any other age group. And women are more likely to be introduced to injection drug use by their male sexual partner. Men are more likely to start using IV drugs because of a friend. And so it's really important that we think about that then when we are looking at treatment, because women, if they're still with that partner, it's going to be really difficult for them to quit. We also need to think about men helping them to find other friends. And this is another one. Women are more likely to use prescription opioids to self-medicate for anxiety or stress. They're also more likely to use men, let me start this again. Women are more likely to use prescription opioids to self-medicate for anxiety or stress, whereas men are going to use it to experiment or to get high. And same thing for alcohol. Women are more likely to drink in response to stress and negative emotions. Men are more likely to drink to enhance positive emotions or to conform to a group. And this is obviously not 100% true. There are plenty of women who are using opioids to go out and get high and have fun with friends, and plenty of men who are drinking because, they don't want to deal with anxiety. But sort of as a general rule, this is true. And so I think it's really important when you get people into treatment that we need to think about women. We need to make sure they have alternate ways to deal with anxiety and stress. And men, we need to make sure they have other ways to have fun, because for many men who get into treatment, they just are not having fun anymore because that's the only way they knew how to have fun and enjoy life. And again, there's substantial overlap between women who are drinking for negative reinforcement and men drinking more for positive reinforcement. But in general, this is true. And I think it's, just something to ask in general about why people are drinking or using substances. And remember, for women, it's more likely to be to alleviate negative emotions. For men, it's going to be more likely to, have fun or have a good time. For methamphetamine use, women often report that they're using the drug because they think it will increase their energy and decrease their exhaustion from work, home care, childcare, and family responsibilities. Women also are a lot more likely to use it for weight loss, and so you need to be asking about that. It's also true somewhat for men, but for women in particular, it's very hard for some of them to stop using because they don't want to start gaining weight, because this is such a big deal for a lot of women. And then I thought this was just kind of an interesting one. The drug screen results often are concordant, more often concordant for women than men. Women are more likely to be truthful about their drug screen results. For men, on average, 86% of the time, their drug screen was in line with what they told you they were using, whereas 96% for women. And 42% of the women always told the truth about their drug screens. Only 22% of the men did. All right. Before I move on, any questions about the differences in how men and women tend to use drugs and alcohol? All right. Next slide. Women tend to get drunker faster than men do. This is for multiple reasons. Women often have a lower body weight. They have less alcohol dehydrogenase, which is the enzyme that breaks down alcohol. They have less what's called volume of water compartment distribution, which is basically how much water do you have in your body to dilute the alcohol. And if you have more water, then you're going to dilute the alcohol more. Women also have less muscle mass than men, and the muscle tends to help for them not to get as, for the men not to be as affected as much by the alcohol. Women also have what we call a telescope course for alcohol use disorder. And everything bad that can happen to men from drinking is going to happen to women with less alcohol over a much shorter period of time. Women have a 50 to 100% higher death rate from alcohol use disorder than men do. And this is not just from liver disease, it's from all causes. They have a higher death rate from suicide. They have a higher death rate from alcohol-related accidents, higher death rate from heart disease, stroke, and higher death rate from liver damage. Drinking as little as 1 drink a day can actually increase a woman's risk of breast cancer, and it may actually be more associated with heavy drinking in early adult life. And women will develop alcoholic liver disease at half the level of consumptions that men do. So, whereas man may need to drink a 12-pack a day to get liver disease, a similar woman might only need to drink a 6-pack. And at any level of alcohol intake, women are going to have a much greater risk of developing alcoholic liver disease. Women have an increased risk for developing cirrhosis drinking 7 to 13 drinks a week. I mean, that's not really a huge number of drinks per week, and it is going to increase women's risk of developing cirrhosis. The CDC defines excessive drinking or risky drinking or at-risk drinking differently for men and women. Binge drinking, which is the most common form of excessive drinking, is defined as consuming 4 or more drinks during a single occasion for women, 5 or more drinks during a single occasion for men. And heavy drinking is defined as consuming for women or men greater than 65, 8 or more drinks per week, and for men less than 65, 15 or more drinks per week. And I would guess probably, about a quarter of the people on this call are looking at that going, well, I drink that and I don't have alcohol use disorder. I'm not an alcoholic, which is true. I believe you. You probably don't, but this is still something that can have a significant effect on people's health. And I think we need to be talking to people about that. It increases the risk for developing alcohol use disorder. It increases the risk of heart disease. All sorts of bad things can happen from risky drinking, even if people never develop alcohol use disorder. And again, most people who drink excessively are not alcoholics or alcohol dependent. Excess drinking is responsible for about 1 in 10 deaths for adults between age 10 to 64. And the health risks of risky drinking, I mentioned injuries, violence, including homicide is increased with risky drinking, suicide, sexual assault, intimate partner violence, high blood pressure, heart disease and stroke, liver disease and digestive problems, cancer of the breast, mouth, throat, esophagus, liver, and colon, learning and memory problems, including dementia, and mental health problems, including depression and anxiety. And there was a great commentary in the Journal of Addiction Medicine discussing whether there needs to be adjustments for these guidelines. Some places issue guidelines. Some countries issue their guidelines based around gender, others do not. Sex and gender have been conflated, so we don't know a trans man or trans woman if they're going to have the same risk as a cis man or woman. So there clearly needs to be more study on this, and it needs to be individualized somewhat. But in general, the guidelines for risky drinking recommend a lower amount for women than men. And gendered low-risk drinking guidelines are far more reflective of gendered stereotype, which men's patterns are normalized, women's drinking patterns are moralized. And we need to think about individual genetics, body fat, body mass, relative water content of tissues, rate of blood flow, liver health, hormone levels, biological rhythms, and liver mass. And I am probably not going to do this on an average visit with a patient, but some things to consider. And I wanted to mention transgender persons and substance use disorder. 5 recent studies indicate that transgender individuals have high rate of alcohol use, marijuana, other illicit drug use, and non-medical use of prescription drugs. And they have more severe misuse of these substances compared with non-transgender persons. And this is not because there's anything innate in being transgender that predisposes to substance use disorder. It is just due to the stigma around transgender in our country. All right, sex hormones and substance use disorder. This is something I think is really kind of actually quite interesting. So the menstrual cycle can be significantly affected by many of illicit substances and licit substances as well. Women who use both marijuana and tobacco have a luteal phase that's an average of 4.5 days shorter than women who just use tobacco. Luteal phase is the second half of your menstrual cycle after you have released an egg. And methamphetamine can cause long-term disruption of the menstrual cycles. Women can get prolonged cycles, they can get shortened cycles, they can get very irregular cycles. And even if they had normal periods, a lot of them had their sex hormones were not normal. And only about 40% had returned to normal hormone levels even after they'd been abstinent from methamphetamine for almost a year. So these can really affect hormone levels for a very long time. This is my favorite. Menstrual cycle can actually affect your likelihood of being able to quit smoking. Women who attempted to quit during the luteal phase or the second half of their menstrual cycle had a much more favorable outcome than women who attempted to quit during the follicular phase. I have not actually gone out of my way to make sure women try to quit during the luteal phase. Every time I give this talk, I think I need to start telling people, wait till the second half of your menstrual cycle and see if they're more successful. And you actually get a much higher response to stimulants such as cocaine and methamphetamine during the follicular or the first half of the menstrual cycle than during the luteal phase. And I don't know if this is at all related to why women are able to quit smoking more often during the second half because of the stimulant effect. Testosterone levels in men are suppressed by both alcohol and opioids. All right, gender differences in incarceration and substance use disorder. Patient is a 32-year-old woman who'd been stable on buprenorphine. She went to jail for 2 weeks. I don't know why. I had heard it might have been shoplifting, but I was never quite sure. The jail destroyed her buprenorphine prescription when she was arrested. The day she got out, I actually spent 2 hours on the phone with her insurance, begging them to please fill it, even though she was not due for her buprenorphine yet. And they did eventually agree to cover it, but by that point she was frustrated and didn't pick it up, and she died of an overdose that night. You all may know that the risk for overdose during the first 2 weeks out of jail is about 20 times baseline rate. Next is a 41-year-old man who first went to prison at age 16. He was involved in a gang-related killing. He feels that it was actually self-defense. He has fairly significant post-traumatic stress disorder from the killing and from prison. He started using heroin after leaving prison and struggled significantly with benzo abuse. He went back to prison in his 30s for drug trafficking. And actually, second time round prison was good for him. He was started on Suboxone. He went through SUD treatment while he was in prison. He had his hepatitis C treated. He is employed and stable with respect to opioids, does have occasional relapses to cocaine. Next, 39-year-old man, opioid use disorder and schizophrenia. He had been stable on medications for both of these. He did not have great executive skills. He got pulled over for speeding, got a ticket, and he didn't pay it. And he got pulled over a second time. They saw he had a warrant out and he went to jail. He was not given any of his medications in jail. I will not go into how very wrong this is, but in any case, he did not get any of his medications. He told me he lasted 5 days in jail in severe withdrawal. He finally, after 5 days, used heroin and then found out he was due to be discharged 4 hours later. At that point, he was so ashamed of having gone to jail and having used heroin that he just continued to use. He also started using stimulants, both cocaine and methamphetamine, which he had never used before. And he used for about 2 months, just really very out of control usage. I was terrified he was going to die. It has been 7 years since this incident. He is still so filled with shame about it that I cannot bring it up because it just makes him spiral to even think about it. He was so embarrassed by this. So men are far more likely than women to be incarcerated. There were roughly 126 per 100,000 women who were incarcerated in the US in 2010, and 1,352 per 100,000 men were incarcerated. The United States has 4% of the world's population. We have about 30% of the world's incarcerated women. I suspect this talk would be different if I was giving it anywhere else in the world. And about 65% of the United States prison population has an active substance use disorder. And another 20% did not actually meet criteria for substance use disorder, but they were under influence of drugs or alcohol at the time of their crime. And so it's really fairly easy to find information on what percentage of people who are incarcerated have substance use disorder. I found it very, very difficult to find any information on what percentage of patients with substance use disorder have been incarcerated. This was the only study I was able to find. And it was a pretty good study. It didn't have quite as much information as there were some things I wish they'd done with it. So what they found in a population-based study in the United States was that 22% of patients with substance use disorder had been incarcerated before. And 10% of the general population, these are adults only, reported a history of incarceration. I think these numbers are incredibly high, that 1 in 10 of our population has been incarcerated and 1 in 5 of our patients with substance use disorder. And so they didn't really calculate the statistics for what percentage of men with substance use disorder versus women, but they had those numbers in there. So I used the numbers to calculate them, so they're not quite as accurate. They said that men with substance use disorder were 2.61 times as likely to have a history of incarceration as women with substance use disorder. And the statistics that I calculated from this were that 32% of men with substance use disorder had a history of incarceration, and 15.4% of women with substance use disorder had a history of incarceration. Again, I calculated these based on, the numbers they had in the study. They are not statistically proven or anything. But but roughly 1 in 3 of men with substance use disorder have a history of incarceration. That can have just such huge effects on people's life, and we need to be asking about it and, getting them help for issues that they need. 1 in 6 women with SUD have a history of incarceration. More than a quarter of women in state prison were incarcerated for drug charges, and 15% of men. 61% of women in federal prison are incarcerated for drug offenses, approximately 50% for men. So the drug war and substance use disorder and incarceration are really very much entwined. And Blacks and Latinos are far more likely to be incarcerated for drug law violations than whites, even though rates of drug use and drug selling are similar. Female offenders in general had more psychiatric symptoms. They more often had a partner with substance abuse. Interestingly, they had lower mortality, and they were less likely to go back to prison. And not surprisingly, if they had a partner who was using substances, they had increased recidivism. Women who had a partner who was using substances had a increased recidivism. And once again, the mortality rate among former inmates is incredibly high. Deaths while they were in prison were 777 per 100,000 per year, per 100,000 person years. In the 2 weeks after incarceration, it went up to 2589 and then dropped back down afterwards. One study showed that opioids were involved in about 15% of all deaths after incarceration. Overdose was the leading cause of death, and overdose deaths in former prisoners accounted for 8.3% of the overdose deaths among persons aged 15 to 84. So until we can make a difference in the death rate in formerly incarcerated people, we're not going to be able to affect the overdose death rate as much as we want. And women who are incarcerated are increased risk for overdose and opioid-related deaths. And then I think we also need to think about the children of people who are incarcerated. I think most of us probably have patients with substance use disorder who had parents who were incarcerated. And more than half of incarcerated people are partners or are parents of minor children, 120,000 mothers and 1.1 million fathers. And 5 million children in the United States, 1 in 14 have an incarcerated parent. This is having a huge effect on children across the country. 1 in 9 children in 2008 had 1 in 9 Black children in 2008 had an incarcerated parent, 1 in 28 Latino children, and 1 in 57 white children. And 84% of parents in federal prison and 62% of prison parents in state prison are housed 100 miles or more away from their children. And this was just kind of a weird statistic. I don't know what to make of this, but people with substance use disorders who have been incarcerated are actually more likely to have had treatment than people who have substance use disorder without a history of incarceration. And just a reminder that methadone programs in prison pay for themselves. An Australian study showed that prison methadone program paid for itself when prisoners leaving the system avoided just 20 days of incarceration. And the vast majority did. The Vermont Office of Alcohol and Drug Abuse Programs found that for each dollar spent on a methadone treatment, you would save $12 to $14 in health and social costs because of decreased crime, decreased healthcare costs, and increased employment. And we do want to make sure we're doing evidence-based treatment in prison and jail. Unfortunately, a lot of times the treatment offered is not treatment that has good evidence behind it. So cognitive behavioral therapy, dialectical behavioral therapy, contingency management, motivational interview, medication treatment for almost all with opioid use disorder. And we need to make sure that we get continuity of care for drug users reentering the community, or we're not going to make any difference in the long term. My statistics include commercial sex workers. I don't have statistics on commercial sex workers. I didn't think to look that up. That is a good one. I will look for that with future versions of this talk. And I've asked my patients what they want doctors to know about incarceration. And here's what my patients have told me. Everyone comes out with PTSD. You are so desperate when you are in jail and withdrawal that you will do anything to get out of it. You will use dirty needles. You will shoot up heroin even though you never used it before. You won't survive if you're weak. The probation system is set up so you will fail. The private prison systems want to keep you in there so they can make money off you. And this last one really touched me. One of the guys looked and tell them to be nice to us, please. So, all right. Any questions about incarceration before I move on? All right. Next, violence and substance use disorder. This patient was a 37-year-old woman. I'd taken care of her for 10 years. That entire time she'd had severe alcohol use disorder and alcoholic liver disease. There was a crisis in the Middle East, and out of the blue, she said, "Did you hear about that crisis?" And I said, "Yeah." And she said, "Did you know I grew up there?" And I said, "No, I had no idea." And I said, "How did you end up there?" And she said her stepfather had been stationed there. And she said, "Oh, yeah, he sexually abused me from the time I was 8 until I turned 15. Couldn't do anything about it because I was in a foreign country. No support. No one would believe me." And she said she started drinking because of this. She was never able to stop drinking and died about 6 months after telling me this. So in community samples, about a third of female children experience sexual abuse by the age of 18. And women with history of childhood sexual abuse are much more likely to have a substance use disorder than women without that history. There's also very high rates of PTSD in women with substance use disorder, partly connected to this sexual abuse history. And a study by Brems et al. Showed that 20% of men receiving detoxification services and 50% of women had a history of childhood physical or sexual abuse. I think we don't ask or think about it nearly as much in men as we do in women, but it's still a fairly substantial rate in men as well. So we do need to be asking about it. And a history of use, these patients are more likely to begin drinking at a much younger age. They probably have more problems associated with the use of alcohol and drugs. They have more severe psychopathology, more lifetime arrests. And girls with a history of childhood sexual abuse are 3 times as likely to develop an addictive disorder. And another study showed that of people entering SUD treatment, 46.7% of the women had a history of intimate partner violence, 9.5% of the men had a history of intimate partner violence. And African American and Native American women were much more likely than women of other race groups to be victims of stalking, rape, physical violence, and these are also risk factors for substance use disorder. And the risk for violence, unfortunately, is increased in anyone with an active substance use disorder. Women with alcohol use disorder have increased risk of unprotected sex, increased risk of becoming a victim of violent sexual assault. Any questions about violence before I move on? All right. Gender differences in substance use disorder treatments. And I was shocked that this went on for quite as long as it did. Until the 90s, the vast majority of research on substance use focused on men. They didn't really start to look at women until the 90s. And male-dominated treatment culture was what we had for many years. And we're actually moving very much away from this now, but I bring it up because I still see some people approaching substance use disorder this way. Male-dominated treatment culture for many years was very confrontational. We're going to do interventions. We're going to confront you about things. And what they found is it doesn't work great for men, but it really does not work well at all for women. Partly because there's so much more trauma in many of our women with substance use disorder. Women generally need a more supportive and less confrontational approach to treatment. And again, confrontation is really problematic with anyone with a history of traumatic experiences. And again, many men with substance use disorder also have trauma. And so we're generally moving away from the confrontational techniques. As far as how men are more likely to get into treatment because their employers say you got to get into treatment. They're mandated through the criminal justice system, and their families say they got to get in. Women are more likely to be in treatment because Child Protective Services said you got to get into treatment. Women are much more likely to be ashamed or embarrassed about their substance use disorder treatment than men are. Not surprisingly, women are more likely to relapse if their romantic partners are substance users. So I think it's really important that we ask about their partners and help to get their partners into treatment if they're interested. And interesting, women are more likely to relapse in the presence of a romantic partner than men are, and less likely to relapse when they're alone than men are. Women are more likely to seek help for substance use disorder in primary care or a mental health setting, whereas men are more likely to go somewhere where they do specifically substance use treatment. And women are also much more likely than men to not be able to attend treatment because of family responsibilities, and they're much more likely to have economic barriers to going into treatment. If they do complete treatment, women do have better long-term recovery. As far as the benefit of gender-specific treatment, it's mixed. There's some evidence that substance-using women with PTSD may benefit from women's-only treatment, and men with combat-related PTSD may benefit from men's-only treatment. And then ancillary services such as childcare may be really helpful to keep women in treatment. It may also benefit some men, but since women are more likely to be the primary caretaker for children, it's more likely to benefit women. And then there's also a lot of co-occurring risks or conditions, such as a history of sexual abuse or psychiatric disorders, social factors like income, education, employment, and the type of substance used, and doing specific interventions around this can really make a difference in the success of the substance use disorder treatment. And since these conditions vary by women and men, if we're focusing on these co-occurring risks and conditions, it's going to make a difference for women with substance use disorder in treatment. So, take-home messages. Women are less likely to use substances or to have a substance use disorder. When they do, the consequences are usually more severe. You want to be aware of the correlation between violence and substance use disorder. Be aware of the effects of incarceration on our patients. Many of our patients, but especially women patients, face substantial barriers to treatment for their substance use disorder. Women with substance use disorder may have substantially different comorbidities and social factors than men do. We want to address these. There may not be actual difference in the substance use disorder treatment per se, but recognizing the different comorbidities and social factors is going to make a difference in treatment.